this is Eileen Shao, and I will be talking about polypharmacy and health disparity in deprived elderly in the US. I've noticed that polypharmacy, which is the use of 5 or more drugs of prescriptive or over-the-counter drugs, is a major health threat that is common not only in my clinic but around the world, yet it has been poorly studied. Sharing with you some background of this project. By 2050, it is estimated that the population over 65 years old will likely hit 83.7 million in the US. The elderly contributes to a fourth of prescriptive drugs in the US. However, empathic care, a practice that involves understanding of perspectives of the patient, is not widely practiced for the elderly. Poor patient-to-physician communication has led to over-medication leading to drug-related morbidities. Data from 2003 showed that out of 200,000 pharmacists in the nation, only 720 have geriatric certifications. And the burden is even heavier for the minority and low-income elderly population, as they often have limited or no healthcare coverage, increasing their risk of worse medical conditions. Looking at current conditions, the bar graph on the left shows the use of prescriptive drugs by sex and age. Prescription drugs were used more frequently in a Medicare elderly population, with higher frequency in women than men, and by older than younger people. The table on the right shows that the out-of-pocket spending and proportion and income proportion between the non-elderly and elderly. It shows that the most disadvantaged subgroup is the low-income elderly group. From current conditions, polypharmacy is a financial burden in the current health system, and it is a predictor for healthcare costs. So the problem defined for my project is that the elderly contributes to a fourth of prescriptive drugs consumed in the US. However, yet polypharmacy-induced mortalities and morbidities is a leaking hole in medical costs. Furthermore, the health disparity is in access to better care, and the burden of disease affects the poor even more. Looking at the analysis portion, society aims to give equal rights for all. However, it does not mean everyone receives equal resources. Pursuing equity requires swimming upstream and understanding socio-ecological factors, which has much to do with stereotypical beliefs that age is associated with higher medical costs. Ageism exists in clinical studies that directly or indirectly influence the structure of the healthcare system and hindering senior well-being. For example, quality-adjusted life years is an indicator that is used in assessing cost-effectiveness of health service treatments. However, it is criticized to be intrinsically ageist on operational or political grounds. Also, during 1991 to 2000, 40% of conducted clinical trials have excluded participants that are 75 years old and above. Social determinants, including accessibility to healthcare, health literacy, marriage status, gender, ethnicity status, and who are not proficient in English, and economic stability are critical factors that need to be examined for this issue, as these are associated with higher risks of polypharmacy, poor patient-physician communication, and less empathic care. That leads to adverse drug reactions that would eventually lead to decline in physiological functions such as kidney failure, memory or cognitive impairment, or death. So the targets and goals for this project seek to decrease the cases of polypharmacy in deprived elderly, improve their healthcare quality, and raise awareness among prescribers about the risks of polypharmacy by including secondary or tertiary prevention measures by coordinating a network of alternative integrated care providers to decrease mortality rates and ultimately reach health equity. My proposed social justice strategy aims to improve coordination and reduce cases of polypharmacy in deprived elderly to achieve health equity by the following 2 methods. First is to establish a case care management system to track prescription use by educating the prescription providers to use the Prescription Drug Monitoring Program, the PDMP, electronic database for case care management. This database provides information on controlled substances or prescriptions and can detect individuals' possibility of multiple medication. Providers should be required to use the system before prescription of medication and integrate their patients' information into the electronic health records. Second is to educate prescription providers of alternative medicine and to coordinate case care management with alternative medicine care providers, such as physical therapy or complementary medicine, such as hypnosis, acupuncture, and healing touch. To conclude, a thorough implementation of drug therapy management system across the nation is in need to monitor an individual's complete list of prescription drugs use in regards to minimizing health disparity linked to age and socioeconomical statuses. Thank you for listening.